case of subacute osteomyelitis of 6 week duration of left proximal third of tibia with current disability of localized pain and swelling with restriction of activities with no without any deformity, instability and limb length discrepancy with no neurovascular deficit. Is
Jagdish sir.
Why do you say subacute osteomyelitis?
Sir, first of all, there's a age duration is the 6 weeks, sir.
Yeah.
And then duration is 6 weeks, and age this is age of the patient is 7 years. This is the most common age, and there is a region. There is a metaphyseal region, and there is no discharging sinus as well.
No, why it can be an acute going into chronic, the intermediary stage? Why do you say that it is not a partially treated?
Because of history, sir. Patient gives history of there is the patient complaining of pain since 6 weeks, which is insidious in one set and gradually progressive, and aggravated on the activity and relieve partially on the rest. And the pain is associated with the swelling and associated with the swelling, which is gradually progressive and achieve current size. For that, he took treatment, local symptomatic treatment at local hospital. That is only medication treatment. And now so he came with the current swelling and the pain at the proximal third of the tibia, left side. And patient has a history of the fever, 2 to 3 spike in last 6 weeks.
Okay.
Yes, sir.
Yes, that history of fever, and there was no whether there was any history of injury. Even it is negative. Even it is negative. Even it is negative that you have to tell.
Yes, sir. There is no history of any trauma, and in past, no history of any surgery, and no any micro trauma at the region. And there is no evening rise of temperature and constant symptom like weight loss.
Why are you thinking in terms of chronic osteomyelitis and not something like a Ewing sarcoma?
First of all, sir, age of the patient. Ewing sarcoma is the more common age is 10 to 20 years, and the region is the most common region for the Ewing sarcoma is the diaphysis. And there is a patient give history of a high grade fever of 2 to 3 spikes in Ewing sarcoma. This
Can occur in Ewing sarcoma.
Yes, sir.
It can occur in Ewing sarcoma. It can occur at 7 years of age group.
Rare in this age group. Ewing sarcoma is rare, sir.
It's not rare.
No, it is not rare in this age group. Even at 4-5 years, you can meet sometimes the Ewing sarcoma.
Yes, sir.
It can occur in the mid. So if the swelling is this one, I can't show it. Is on the left leg. It appears to be in the metadiaphyseal area.
Yes, sir.
So that is again a common site.
Yes, sir.
No, don't go ahead. As
Yes,
Sari is asking, you try to answer those questions. No point in going ahead with the slides.
Yes, sir.
Sari is asking why you tell that this is not Ewing sarcoma and this is subacute osteomyelitis.
First, sir, age and the second is the region mostly occur in diaphyseal region, sir.
Already you have told 2 points. One is the
Yes,
age.
sir.
You
Yes,
tell
sir.
that age is not, this is not the age for the Ewing sarcoma. Second, you told that
the region, this is the type.
Area means you are telling this is the metaphyseal diaphyseal area.
Yes, sir.
Okay.
Sir, on examination, I found there is a abscess. The soft in swelling is soft in consistency, and the tenderness over there, localized bony tenderness is there.
Okay.
Yes, sir. And
Where is the bony
am
tenderness?
I,
You have to tell, specify that
yes,
where.
sir. Bony tenderness on the anteromedial aspect of the proximal third of the tibia, sir.
Okay.
With the
So is that abscess common in subacute osteomyelitis?
yes, sir.
Soft tissue abscess.
Soft tissue abscess.
Soft tissue. Yes, sir. Mostly in the acute osteomyelitis, sir. But the is as the duration is 6 weeks.
Nikhil, how did this start? How did this start? What is the beginning and when?
Sir. First, he complaining of the pain at the proximal third region, and after 3 to 5 days, he his father appreciates swelling at the proximal third of the tibia. Then
Okay.
for that and he restriction of activity while playing. Then and one spike of the fever at the 1.5 month back. Then his father goes to local hospital and taken symptomatic treatment. After that,
So,
again
are you, no, no, just a question, Nikhil. Are you trying to say that there was no acute presentation? There was no fever and severe pain?
no, sir. Patient can walk comfortably,
No, no, I
and
mean,
pain on
no.
only walking, mild pain on walking.
No,
Walking, sir.
what you are trying to
And
say is there was no acute picture. Correct.
no,
That's
sir.
your diagnosis of subacute.
Yes, sir. Yes, sir. No acute, sir. Gradual increase in pain and swelling, also.
So there is no acute severe pain, fever, and the child appearing ill. That kind of picture is
No,
not
no, no, sir. No, sir.
fine. And palpation findings. What about tenderness?
Sir, on
Breast.
palpation finding, there is a local rise in temperature, sir, and there is
Go ahead.
sir, there is a tenderness present over the proximal third of the tibia, and on anteromedial aspect of the bone, there is the
Interfacial,
I feel
diaphyseal, you have to specify now, isn't it?
yes, sir. There is a tenderness present over the proximal third of tibia, and there is a bony tenderness, and at the anteromedial metadiaphyseal junction, sir,
Okay.
with felt irregularities.
Okay. What about thickening when compared to the same side on the opposite tibia?
There is thickening of the there is thickening. Yes, sir. There is skin is edematous. Skin
Thickening
is
of the tibia. So he could be having
yes, sir.
cellulitis, isn't it? We
Mm,
want to say the focus of infection is in bone. So
no, uh, in cellulitis there is the like PUD orange type appearance and bleb formation also
yeah,
in
no.
skin.
Question is you have to tell some findings which help us to say that the bone is infected. So
As a bone,
bony tenderness is
there is a
correct.
bony tenderness, sir, and again there is bony tenderness and there but there's a pain on exertion, sir. Pain on walking and exertion, and while playing.
What about rest pain, pain at rest, pain in the night?
No, no, sir. No pain at no history of night pain at night, sir, and no history of evening rise in temperature.
Anything else relevant in the history? Some other sepsis elsewhere in the body?
No, sir. There is no any history of previous history of infection in body, sir. And otherwise, child is playful, and he's performing his activity.
Yeah. Any other, like sir was asking, how did you rule out any other differential diagnosis from the history and all? Can it be a tumor?
Sir, first is the osteoid osteoma. There's which is ruled out by the night pain, which is the typical night severe pain, and which is relieved by the taking of the aspirin. There is no history of night pain. First, second thing is the any history of tuberculosis, like no no constant symptom like a weight loss. Then evening rise in temperature, and there is loss of appetite.
It's stuck in between, I think. No?
Yes, though
What else?
the third one is Ewing sarcoma, sir. That's rule out.
Yeah, how did you rule out, sir? Already asked that. That's an important
Yes, sir.
question which will be asked you. How will you rule out its Ewing's?
Rest pain. Rest pain. It is only in my the osteomyelitis. There is a condition mechanical type pain, and in Ewing sarcoma there is rest pain.
Short history, isn't it? You said some
Sweets.
sudden onset.
6 weeks.
There is in my case there is a there is insidious in one set and gradually progressive. But Ewing there is a malignant aggressive tumor. That's why it is a very sudden in one set and aggressively progress.
Yeah, I don't agree with these statements because Ewing's is one tumor that remain dormant. Even if you read books, it may remain dormant for even years. Okay, so Ewing's is a peculiar tumor. It doesn't come so with so big swelling, fever, and other things. Okay.
Yes, sir.
It is not having an acute onset. Ewing's is one which often present as an osteomyelitis.
Okay.
And even you are going to get soft spots in the swelling because the tumor is fast growing and it becomes necrotic. So when you do an IND, you make it first like material.
Yes, sir. Okay.
Okay.
Yes, sir.
So your answer to my first question, why do you say it is osteomyelitis? The best answer would be you will consider Ewing's as your differential diagnosis.
Yes, sir.
So that is a better answer because it
Yes,
can
sir.
occur at 7 years. It can occur in the metaphyseal diaphyseal area. It can appear with the soft swellings. It will have this 6 weeks or more duration, even years. I think if you read that Tashian pediatric orthopedic books, they say that it can remain there for more than 1 year.
Yes, sir.
Okay. Then they can present with fever. Constitutional symptoms is a feature. So you should keep it as your differential diagnosis.
Yes, sir.
Okay. Any other differential diagnosis?
Sir, second is osteoid osteoma, sir. Then
Yeah.
There is a soft tissue abscess, like other tumor osteosarcoma also.
I think it is better you tell the physical findings also. What did you see on looking at the swelling, on feeling the swelling? Okay. On
Yes,
moving
sir.
the limbs. You just tell all this. Any other similar swelling as Jagdish was asking. Why he was asking for similar swellings?
Because of sir, multiple like CRM, chronic recurrent multifocal osteomyelitis. Sir.
Osteomyelitis. So you just tell the findings.
Yes, sir. There is
inspection,
no other swelling in the body, sir.
No. Inspection, what did you find?
On inspection, sir, I first appreciate the swelling on the proximal 1/3 tibia on anterior aspect, and the skin is which is shiny and glistening, with slight edematous and inflamed, and then there is slight wasting at the region of distal femur region also, and there is the on negative finding like there is no discharging sinus or there and scar of previous surgery and dilated vein also, sir.
Okay.
And palpation, yes, sir. On palpation, there is a local rise in temperature is there, sir, and there is a localized tenderness or the swelling at the proximal third of tibia on anteromedial aspect. Then inspectory finding I confirm in which swelling is soft in swelling is the oval shape swelling is there. Then soft which is soft in consistency and ill-defined margin of the swelling and bony tenderness is there, and I felt irregularities over the proximal 1/3 of tibia at metadiaphyseal junction, and there is no any instability over the region.
Any thickening nearest?
Yes, sir.
Any thickening is there? Thickening of the bone?
Yeah, yes, sir. There is irregularities and a thickening of bones, sir, felt on palpation, sir, with bony tenderness on anteromedial aspect.
Do you consider any general examination findings?
Yes, sir. First, build, sir, the patient's build, because the malnourishment is the one of the could be the cause of the
I meant to
osteomyelitis.
say, should you think of unusual diseases like fibrous dysplasia? Should you think of a stress fracture?
Hmm. Yes, sir. We can say stress fracture is stress fracture, sir.
Can you get fibrous dysplasia and you get some skin markers? Maybe you can put your diagnosis.
Um,
So the presence
Skin
of
markers for fibrous dysplasia.
yes,
what is the skin marker?
Skin.
skin
What spots will be there?
uh, cafe or
Cafe
that
au lait spot. Okay. Which type of cafe au lait spots? Is it regular like
irregular.
Great cafe.
yeah, or irregular like the coast of mean? Which one?
Irregular cost of money. Yes, sir. Cost of
Main appear.
yes, sir.
What is a significant fibrous dysplasia? A significant cafe au lait spot? When will you say that it is significant?
Significant number of 4 to 5 spots. More than 5 spots.
More than 5 and size?
Size of 2 to 4.
This in children, more than 10 millimeters in adults. In children, up to
4
50 millimeters.
more than adults. 2 to 4. 2 to 4 centimeters. Sir. More than 5, 2 to 4 centimeters.
Not, it is millimeters.
Okay.
Then,
5 millimeters.
5 millimeters.
Yes.
5 millimeters.
Yes.
Not sure actually. I don't know. I don't remember.
Simply, you remember coast of California and coast of Maine. Coast of California, you see in the neurofibromatosis.
Neurofibromatosis.
It is commonly associated with congenital stroke. That is, C stands for C. It is a smooth round one. And coast of Maine. Maine means M. M stands for it is an irregular one that is seen in the fibrous dysplasia. It is
Yes,
fibrous dysplasia. C stands for it is a smooth line that is coast of California, that stands for neurofibromatosis. It is no doubt you can easily remember with this.
Yes, sir.
And size in the children, it is 5 millimeters more than 6.
More than 5 to
In
6.
adults, it is more than after skeletal maturity. You can say that it is after skeletal maturity and before skeletal maturity. After skeletal maturity, it is 1.5 millimeters. More than 6. That is a consideration.
1.5 centimeters.
Yes, sir.
Yes, sir.
What else are unique lesions to the tibia? When the tibia comes, you should think of certain diseases. What are they? It's a possibility.
Yes, sir.
Dysplasia is a possibility. What is osteofibrous dysplasia? Osteofibrous lesion.
Campaign something.
So many things, like for example, adamantinoma. Again, it's a tibial lesion, isn't it?
Yes, sir.
When tibia is there, you must think of certain lesions, isn't it?
Yes, sir.
Have you heard osteofibrous dysplasia? Not fibrous dysplasia. Osteofibrous. Large non-ossifying fibromas.
Yes, sir.
Okay, though fever part kind of rules it out, isn't it? If you have fever, it's unusual.
Yes, sir.
It can be osteosarcoma.
It can be
Metaphyseal child.
Yes, sir. Mm, the pain is not that severe, sir. And swelling in osteosarcoma, there is a swelling, and on inspection, there is a slight dilated vein also on
You see
region.
total rise of temperature, isn't it?
Yes, sir.
So what the purpose of this, Nikhil, is to understand it's not always very simple. Though for it may be a simple diagnosis, but the discussion might go anywhere. It
Yes,
might
sir.
land up in tumor. So you must be prepared also.
Yes,
So always think of history. History in a malignant tumor will be what? Pain followed by swelling,
yes.
night pain. So like
Night.
that, from these are the points against it being osteosarcoma. In the history, these are the points. On inspection, these are the points. Like that, if you tell, that will be very useful.
Yes, sir.
And also the way of your presentation. See, you have presented it as swelling.
Yes, sir.
You particularly use the word swelling. You know, swelling is a tricky word. You have to differentiate it from other adjectives like prominence, fullness. When we say swelling, it means that something is growing from the bone, or the bone itself is expanded. So there is a subtle difference. It depends. See, it's like your general surgery. A lipoma is a swelling.
Yes,
Isn't it?
sir.
But if you have, say, pedal edema, you will not call it swelling. You will not call it swelling. You will say there is prominence or there is fullness in the ankle, isn't it? So when you say swelling, you are also opening a door for malignant tumors and other tumors. When you use the word swelling, it's not possible to draw and show here. But if you have an outgrowth from a bone, like an exostosis will be presented by you as a swelling. Just like
Yes,
in
sir.
MBBS you used to present a lipoma or a sebaceous. That will be the presentation. It will be like a
Yes, sir.
swelling. But some diseases will just produce fullness. That you have to differentiate from. You cannot call everything swelling.
No, sir.
Swelling sometimes gives the meaning that there is a mass.
Yes, sir. But like in this swelling, sir, swelling is a cystic, like a soft in consistency, and which is the like fluctuant and ill-defined margin also, and gradually which is progressive.
So where is this plane of the swelling?
Uh, it is a
From where is the cystic swelling? Where is it?
and
You said it is a intermediate aspect, Nikhil.
intermediate aspect, sir. Yes, sir.
So
The
intermediate,
intermediate.
it is over the bone.
Yes, sir. It is over the bone.
So
But
in
it
the
is
margin,
slight soft. There is a it feel like there is a fluid or pus beneath the that soft consistency.
Sir is asking plane of the swelling. Plane of the swelling means is it in the skin or it is
No,
superficial to the deep fascia or it is deep to the deep fascia or it is within the muscle. That's what sir is asking. You just listen the question.
yes, sir.
Sir, plane of the swelling means is it in the skin or in the superficial fascia or deep to the deep
Sir,
fascia
deep
or within the muscle? You just tell.
deep fish, yes, sir.
Below, above.
Below the deep fish.
It's a difficult thing to find out, Nikhil. सोच के बताओ.
Yes.
you know
Yeah.
what are the margins? Could you feel any irregular margins around the abscess?
There's a because of bone, sir. There is a it may be the bony destruction due to bony destruction and the irregular margin of bone.
And what is there in ear in this case? If an irregularity is there, anything?
Yes, sir. I felt irregularities on intermiddle, just on the sheen of the tibia, sir.
Irregularity is there.
Yes, sir.
So that means bone is destroyed and something has come out. The fluid has
Yes.
come out or abscess, whatever it is.
Yes, sir. Abscess.
Abscess
Bony.
you cannot call. You don't know whether it is because in the Ewings also the something the fluid looks like an abscess. Okay.
Yes, sir.
The necrotic material looks like abscess. So you cannot call it abscess unless you just verify otherwise.
Yes, sir.
So
What about the lateral and posterior surface of tibia? Is it also thickened?
No, sir. Lateral and posterior surface is normal,
Normal.
not thickened, and no irregularities there, sir. And no tenderness also, sir. Yes.
So if it is like that, what type of subacute osteomyelitis is it?
It is according to the and type 2. There's a metaphyseal region with cortical destruction. The
Whose classification?
this is radiologic classification, and other one is the Garthill classification, sir, in which there is a type 2, which is which is the metaphyseal radiolucency with cortical destruction.
This is a radiological
Nikhil's
classification. That used to
classification.
be called
Right.
Gledhill problem. And then
Yes.
there's Ernie.
One more classification, sir. Robert class.
With destruction and all,
Yeah,
you said what?
modified by Robert.
Yes, sir. Modified by Robert. Sir.
So in that it comes under, I think first one, if I
1B.
remember correct, is central metaphyseal, cortical metaphyseal. Third is third and fourth are diaphyseal.
Diaphyseal, sir. Epiphyseal.
No, fourth is the diaphyseal with periosteal reaction. Fifth is epiphyseal. Sixth is epiphyseal
metaphyseal, sir. Yes, sir.
So 2 metaphyseal, 2 diaphyseal, 1 epiphyseal, and
Epiphyseal.
1 epimetaphyseal.
Yes, sir.
Okay.
So what do you want to keep your, what about other findings? Is there lengthening, shortening? Is the iliac nodes enlarged?
No, sir. There is no a limb discrepancy is there. Any deformity, any instability is there. Sir. And
Now that's it.
yes, no neurovascular deficit, sir. And full range of motion of knee and the ankle, sir.
So what will put your?
Is there any wasting?
Yeah.
Yes, sir. There is a wasting of the left distal femur region, sir. It may be due to a disuse atrophy.
But you said he is walking and without any problem.
Yes, sir. He has slight pain on while playing.
Okay.
Yes, sir.
Can be tuberculosis.
Sir, in tuberculosis, there is a first thing is there is a constitutional symptom is there, sir. There is a local rise.
He had fever 3 or 4 times.
The local rise in temperature. There's a weight loss. There's no history of weight loss or loss of appetite, sir. And there is no history of in family history of any Cox contact.
But still, you can keep a differential diagnosis. You are thinking
Yes,
in
sir.
terms of infection. I think you cannot rule out tuberculosis by simply the absence of consciousness symptoms.
Yes, sir.
Not always there in every case. Okay.
Yes, sir.
So these type of because the pyogenic usually unless the cells are said subacute, the chronic and acute behaves in a different way. Okay.
Yes, sir.
So I think you can keep it tuberculosis osteomyelitis also one of the different diagnoses.
Yes, sir.
How will you proceed?
Sir, I will go for the investigation in the form of the lab diagnosis and the X-ray. In lab diagnosis, I will do complete blood count, then WBC count, and the C-reactive protein and erythrocyte sedimentation rate, sir. And there's an X-ray of the full length tibia with the adjacent knee joint and the ankle joint, sir.
AP lateral.
And epilateral.
Yeah, and if you have the X-ray, you can show it to us.
Yes. This is walking video, sir.
What is
Right of gate.
Nikaji, huh? Is there any finding, Nikhil? I can't see. It's actually running horizontal.
Yes, sorry, sir.
So
No, sir. The gate is normal, sir.
normal gate. Okay.
Yes, sir.
Fine.
This is a plain X-ray. This is a plain X-ray of immature skeletal showing full length tibia fibula with knee joint and the ankle joint. With there is a obvious swelling. There is a obvious swelling is there in proximal one third of the leg. With there is a cortical destruction is there in anteromedial cortex in AP and lateral both view, and there is a radiodense sclerotic bone surrounding by the radiolucencies, most probably the sequestrum in the infected tissue of the pus, and there is the loss of the corticomedullary differentiation, and there is the physis of the proximal tibia, distal femur, and the distal tibia appears normal and not fused.
No, there is a soft tissue swelling also, obvious soft tissue swelling.
Yes, sir. Obvious soft tissue swelling is there, sir.
Around the region.
Yes, sir.
On the medial part of the physis, just below the physis, there appears to be a dark shadow. What is that?
Maybe, sir, the radiolucent area, sir, but there is no pain and tenderness over there, sir, and a knee joint motion is.
We are discussing only radiology.
Don't talk like that. Nikhil,
Yes,
you describe what is the possibility it is. The swelling is
Uh,
that is lesion exists in the X-ray. Just explain it. That's all you have to do.
the that physial bar, no,
Yeah, that one.
just physial bar,
Bar.
no, sir, the sclerotic, that actually. It's the radiolucent area which is surrounding.
So isn't it likely that the same pathology is going on there also?
It could be, sir, but in this age group it is rare. As it if it is less than 2 years, there is a immature physial barrier. So there is a.
That's not the right way to talk. That there is a
Yes,
lesion.
sir.
You need to explain it.
Yes.
So if there is infection 3 centimeters from that, isn't it logical that is also infection?
Yes, sir. It could be. It could be the foci of infection, sir.
It could be another foci. It could be
Yes,
another,
sir.
isn't it?
Yes, sir.
That later we can rule out. There are so many ways to find out, but that's the way to explain it.
Yes, sir.
Obviously, there is a nidus of infection at the metaphyseal region, subphyseal location. You can tell like that also.
Yes, sir.
Is the tibia longer than the counterpart? Lengths are correct. Huh?
Yes, sir. Length are correct. I measured, sir.
Okay.
I have measured length, sir. There is
Fibula appears
I think I written
compared to the
measurement, sir. Tibia 24 centimeters on both the sides, sir.
Clinically, picture appears like it is lengthened.
Yeah, exactly.
No, since pelvis is
Clinically
tilted,
also
sir.
it appears like lengthened. Can you show me the clinical picture?
Yes, sir. I have taken that pic in pelvic is slightly
This one
tilted, sir.
You can see that on the left side, the medial malleolus, how it is a little
No,
bit
sir.
lower appears.
The pelvis is tilted, sir. Then I clicked the photo,
okay.
and this side is standing fixed, sir.
You showed the Alice Galizzi, no? That's a good this thing.
Yes, sir.
Next slide, Nikhil, you show. Yeah, that one.
Yes.
Yeah.
That one.
That is also not
So,
correct.
but doesn't appear to be much discrepancy there.
Yes.
Except that because the pelvic tilt is this,
Yes,
appears that left side is.
So the X-ray, it
Yes,
looks
sir.
fibula is a little shorter than the tibia. That's all. So what's your radiological diagnosis now? Remember, you took number 1 as you said subacute osteomyelitis, isn't it?
Yes, sir.
Subacute osteomyelitis, Ewing sarcoma,
Ewing sarcoma, osteoid
dysplasia, osteosarcoma, osteoidostoma,
Yes, sir.
isn't it?
Stress dysplasia, adamantium.
Dysplasia, yeah, so many things. Now, what has the X-ray told you extra? What do you think now you're dealing with?
First, there is a zone of cortical destruction, sir, and a cortical destruction with it could be probably sequestrum formation.
No. Again, you have to choose. Is there cortical destruction, or is there a lytic lesion in bone with cortical hypertrophy? What are you trying to tell us? Cortical.
Sir, in lateral view, sir. Yes, sir.
Lateral view. With the
In lateral view, sir, there is a
destruction of the anterior cortex.
anterior cortex, sir. Yes, sir.
Yes, good. Yeah. And then you have to say there's a lytic lesion, isn't it? Measuring so much from so much.
Yes, sir. The sclerotic bone surrounded by the lytic lesions, right? Lytic area. And then this one.
And where did you see the sequestrum?
Mostly after the 3 months.
No. Is the sequestrum visible on the X-ray?
Yes, sir.
Where is the sequestrum?
This one.
And in the lateral you can see. Yeah.
Yes, sir. Laterally and lateral X-ray, and this is on AP view. This could be the X-ray. This is rounded part.
How do you know whether the sequestrum or involucrum, Nikhil?
Sir,
Radiologically.
Sequestrum is a radio dense, sir. Sequestrum is a radio dense and and sclerotic. Sequestrum radio dense and sclerotic. And
Nikhil.
Yes, sir.
Sometimes involucrum and sequestrum they are equally dense. But how do you differentiate between these two?
Sir, which is separated from the viable bone, sir, sequestrum.
Yeah, yes, that should be the answer. Yes. Because the sequestrum is always seen separate from the viable bone.
Yes, sir.
And involucrum is always in continuous with the parent bone.
Parent bone, sir.
Yes, that should be the answer. Okay, good. But I still feel it is
sequestra? What are the types of sequestra?
So yes, sir. According to the shape, it is the tubular, cylindrical, then corolliform sequestrum, then conical sequestrum, pencil like sequestrum, sir, and ring sequestrum of the Steinman pin. And according to color, sir, there is a black color sequestrum, and a green color. There is a pseudomonas, and like feathery in pyogenic and syphilis, sir, and coke-like sequestrum.
And sand sequestrum?
Yes, sir.
I am adding one more thing. Sand sequestrum.
Sand sequestrum.
Sand.
Why it is radio dense?
Sir, because the avascular bone is avascular, there is no blood supply, and there is no resorption activity. First, second thing is that it is in a radial. It is surrounded by the infective material, which is radiolucent, and the hello.
Share your screen.
Maybe he lost his connection.
Nikhil, try to join again.
Yes, sir.
Hello, am I audible?
Yes, you are audible. Share your screen.
Yes, sir. Sir, 1 minute, sir. My laptop is switched off.
Gopakumar sir, till the
Yes.
time Nikhil is getting his connection, sir, kindly tell us about sequestrum, likely questions asked in the exam, and how much precisely we should describe the sequestrum. Gopakumar sir, please.
Yeah. Sequestrum is the dead and infected bone. So they may ask you why it appears clinically. What is the evidence of sequestrum when you get a sinus? The usual expected answer is sprouting granulation. When there is sprouting granulation at the mouth of the sinus, that indicates that there is dead bone deep inside the
Sir,
bone. Okay. He's back now.
Yes, sir, he is back.
Yeah.
I think at the
Yes,
end, I will request you
so,
to.
sir, which is radio?
Yes, Nikhil.
Hello, sir. Yes, sir.
Yes, go ahead.
Sir, as Kumar sir asked the question that why it is radio dense. So it is first of it is the avascular. That's why no any resorptive activity. Second, which is in a surrounded by radiolucent area because of the any infective material or the pus. And third one is the normal bone, any reactive bone, that is involucrum, which is hyperemic, and that's why it looks more dense or sclerotic.
And also there is no remodeling process, and calcium salts are not drained away. No remodeling process there in a dead bone. One of the given the textbook. Sir, Gopakumar sir.
Yeah.
Sir, because it is it looks like infection only, but could it be tuberculous osteomyelitis, sir? Tuberculous osteomyelitis.
Usually, this type of large sequestrum is not seen in tuberculous osteomyelitis. And he said clinically there is an
Yes, sir. No. Yes, sir.
Clinically, there is an abscess which he is able to feel, and there is sequestrum. So with these findings, I will not put it as acute osteomyelitis, subacute osteomyelitis. I think chronic osteomyelitis.
Chronic osteomyelitis.
Because sequestrum is a feature of chronic osteomyelitis.
I think only because of the timing of the disease, he is telling from the history, it is like a subacute. Because I think in the exam he is correct that he has to present like a subacute because you are not supposed to see the X-ray. Because there is no sinus, no discharge, and the timing, all are you are correct that you are supporting for the subacute. Correct, Gopakumar sir?
Yeah, after seeing the X-ray, he can tell that sequestrum is a feature of chronic osteomyelitis.
Yes, yes.
So point
because it is diaphragmal in nature, can we radiologically make a diagnosis? Any sickling can osteonecrosis and sickling can come into the differential diagnosis, sir.
Yes, sickling.
Yeah, definitely you can. You should think of sickling if they are coming from an endemic area.
Yes, yes.
But
it is multifocal, acute onset, multifocal, and all other generalized signs are also there.
Yeah.
Along
with that, if you look at the femur, they will have bone infarcts. Usually, these bone infarcts are getting infected.
Yes.
Yes, sir.
And it is very painful also. We get a few cases from Wayanad and Attapadi. So we are seeing these cases.
Nikhil?
Yes, sir.
Just keep that extra in
Yes, sir.
position.
Yes, sir. Yes, sir. I have some network issue.
Right. Okay.
Consider a tumor. Should we still consider it Ewing sarcoma in this patient?
Yes, sir.
It would be a cortical erosion. Soft tissue mass with cortical erosion is another way. The onion peeling need not be there always. So sometimes
Yes,
it
sir.
is as actually a subperiosteal mass which eats and erodes into bone. Obviously, there will be no sequestrum there.
Yes.
That will not be there.
No, no onion spill.
No, that is what I'm saying. It is not necessary to get onion peeling in Ewing's. It is a classical presentation, but
Yes, sir.
not necessary that every patient should have onion peeling.
Nikhil,
Yes, sir.
remember one thing, infection can mimic malignancy, malignancy can mimic infection.
Yeah.
That is a standard quotation you always should remember. Whenever there is a destruction with a newborn formation, you can always you have to think of both things together, because rare, not classical always. Okay,
Yes.
need not, but you have to have a more support. What is the positive funds towards infection, osteomyelitis? That you have to see. What is the cavity, sequestrum, and inner These 3 points you have to concentrate. Okay.
Yes, sir.
But usually in the infections, you don't see so much of soft tissue swelling. Unless it is an acute osteomyelitis. Okay. But
Yes,
as far
sir.
as my knowledge is concerned, acute chronic, usually you don't see so much of soft tissue swelling.
That's a critical point to differentiate infection from tumor also. So if you have a large soft tissue mass, you should think more in terms of tumor.
Tumors.
That because the tumor will throw up. See, just imagine that the vertical dimension of this lesion is about, it's about let's say 10 or 15 centimeters. Remember, a tumor will be expanding circumferentially. So horizontally also it will throw up this almost a similar kind of dimension. So in that case, the soft tissue mass is the one that actually pushes you towards tumor rather than infection.
Yes, sir.
If you have an abscess, then more confusion, isn't it? If you have a soft fluctuant swelling and all, then you still can. That's why they say, like Uday Kumar sir said, isn't it? Somebody says that biopsy what you culture and culture what you biopsy. Same way of
Sir.
isn't it?
I had one better experience, sir, Jagdish Menon, sir.
Sir.
It was diagnosed by a senior most orthopedic surgeon as an abscess, and because he could not go to him, he wanted me to incise it, do IND.
Correct.
When I did IND, some purulent material is coming from the ileum posteriorly. So because I was very young and initial stages of my practice, I thought what it could be. Then when I sent it for biopsy, it came out as Ewing sarcoma, sir.
Oh, wow. Can happen, sir. Can happen to anybody.
Then that fellow ultimately died in 6 months' time. It's almost 20 years back, sir. Correct. Almost in the very initial stages of my practice, maybe 89, 90, sir. 90s, 90, 89, 90.
Nikhil?
So our
yes, sir.
How will you proceed further now regarding management?
Sir, I will counsel the patient and the relatives regarding the surgery. As it regarding
Nikhil,
the surgery. Yes,
Nikhil,
sir.
are you not going to do any further investigations apart from the routine blood and X-ray? Are you
Yes,
not
sir.
going to do MRI?
Yes, sir. I will go for the MRI to differentiate it from any.
You have to take an MRI.
Yes,
For
sir.
any doubt, if you have any doubt, it is an infection, could be a malignancy, then it is mandatory to take an MRI.
Yes, sir.
Then you have to proceed with the.
Any other investigations apart from MRI, Nikhil? X-ray, MRI, any other investigation?
CT scan to see the better
Why CT scan? Any other investigations? Less radiation?
Bone scan.
Yes, bone scan.
Bone scan, sir. Technique. technetium 90 and bone scans.
A request to the students, please don't write answers on the chat box. Okay. So how will you proceed further?
Then I will consult the patient and the relatives regarding surgery, sir, and I will go for the.
What surgery, Nikhil?
Yes, sir.
What surgery? You have to tell them what surgery you're going to do.
Yes, sir. Debridement and sequestrectomy, sir. Debridement and sequestrectomy, sir, with the removal of all the necrotic and infected bone and soft tissue, sir, and saucerization after that.
Do you want
And
to aspirate the soft swelling before going in?
Yes, sir. I will aspirate.
If you have an ultrasound guidance and you can see an abscess.
Yes, sir. I will aspirate. I will aspirate and collect the sample for the histopathology culture purpose, sir.
Should you start antibiotic before all that?
No, sir. No, sir, because it will mislead culture sensitivity, and there we obviously sequestrum on the X-ray, sir. That's why we go for the sequestrectomy.
No, do you? Our question is, do you want to confirm your diagnosis before any another non-invasive invasive, something like a aspiration or a white bone needed aspiration or a white bone needed biopsy? Don't you want to confirm your straight away you adopt surgery, or you want to you want further confirmation? Suppose you have a doubt with it could be a malignancy also. How can you tell that is a sequestrectomy straight away?
Yes, sir. First, I will confirm with the aspiration.
No, white bone needed aspiration and other investigation you must make sure before you put your knife on it.
Yes, sir. Like MRI and bone scan, sir.
Okay, bone scan will come into picture when you have a doubt that it have a metastasis. Sir, what is your opinion, sir? Jagdish Menon, sir?
No, I think, but classically, if we are taking the MRI or MRI, I think you can go ahead directly with your plan rather than putting the aspiration once and then again coming wait for some time.
No, if he says fluctuant swelling, then definitely I'll put a needle.
Sir, under fluctuant swelling, I think you can put a needle, sir. Simple, very simple procedure.
No, I am telling you, I think in one go, suppose in the OT, I take it for the patient, I will send this thing for needle, and same time I will go ahead with the same day with the definitive surgery, not like putting the needle one time and again wait for some time, second time I go ahead after 2-3 days. What's the opinion of Gopa, sir?
I think nowadays it is mandatory to get a biopsy report prior to doing definitive surgery in all doubtful cases. So there is no harm.
I am talking of this case. I am talking of this case, sir.
Yeah, if we are suspecting, here it appears to be osteomyelitis. If the MRI confirms that it is osteomyelitis, you can aspirate it, send the material for culture and sensitivity. And in children, we don't do an extensive sequestrectomy. Because we will wait for the involucrum to appear. Otherwise, there will be a lot of dead space there. So the classical treating is.
Question is that, Gopa, sir, on the same day you go ahead with the surgery. That is my opinion.
Yeah, if in this case, I think it is just osteomyelitis, and you can get an MRI and confirm that. And in that situation, you aspirate, and if you are getting pus, there is no harm in doing it.
Go ahead with the definitive surgery on the same day.
Sir, I would immobilize. The fact that there is an abscess means there is an acute exacerbation. This is obviously not an acute osteomyelitis, but an acute exacerbation of chronic osteomyelitis.
Yeah.
I would put a slab, aspirate the swelling, do a blood culture also, send these reports, start a broad spectrum antibiotic, wait for the reports, and then go in.
Okay. Second time you are going in. Okay.
Yeah. That's what I would do.
Will you stop sharing your screen?
Yes, sir.
Because the classical old teaching was in small children, 7-year-old children, you should wait for till involucrum to appear before doing an extensive sequestrectomy, because many of these sequestrum get absorbed. That was the teaching. But I don't, it has changed quite a lot, but many of the senior examiners would like to get that answer. So, Jagadish, what is your opinion?
Sir, I would agree with you, sir.
Yeah.
Though I think that the trend is more and more operative now.
Yeah.
People would like to operate as quickly as possible, but I would wait also. I would just do the same thing because I think because there's a soft swelling, there is definitely it's a abscess. That means there is acute suppuration going on. So I would aspirate before I go in. And maybe the clinical symptoms might improve with antibiotics, giving time for involucrum to form. And if we do extensive surgery also, there is this risk of causing a pathological fracture. It's already a large lytic lesion.
Yes,
If
sir.
you move too much, it might even break.
Almost 70 to 80% environment is there. Sir. So you may be left with only 10 to 20% of bone around.
Yeah, only fear is if it is very close to the physis and all, then I would not probably delay and do all that, because we don't want the child later to develop a deformity and destruction of the physis. So if the MRI shows a lot of the metaphyseal edema extending to the physis, probably that I'll do surgery the next day also. Decompress the metaphysis also, trying to save the physial from any infection.
Infective injury, yeah.
Sir, we are having 20 minutes in our hand. I think if all the faculties agree, I would like Gopakumar sir to sum up this case presentation, and then short presentations regarding homeworks we would like to do. And before that, I would like to ask Nikhil to make a presentation on next time short PPT on principles of debridement.
Yes, sir.
Any debridement for that matter. And then
Yes, sir.
second, a few slides for principles of management of chronic osteomyelitis based on Shearney and Madar classification.
Yes, sir.
Okay.
Yes, sir.
Anything else we would like to ask Nikhil to do in short presentation, sir? Gopakumar sir.
Yeah, he can tell about sequestrum because it can be asked.
So
what is sequestrum? What are the types of sequestrum? How do you manage sequestrum? And
yes, sir.
So regarding sequestrum, everything try to make 3-4 slides, Nikhil.
Yes, sir.
Jagdish
Yes,
sir.
No, I thought if you're adding a one slide on Brody's abscess, that is also a short.
Yes, sure, sir.
Okay.
Yeah.
Then chronic osteomyelitis, subacute osteomyelitis of Gare, I think there is some sort of this terminology is there. Okay.
Yes,
that is a good idea, sir. Maybe subacute osteomyelitis itself is a good idea.
So subacute osteomyelitis, make a presentation, and then principles of management and everything whatever information you can gather regarding sequestrum.
Yes, sir.
Okay, and then
yes,
basic definition of sequestrum, involucrum, acute osteomyelitis, subacute osteomyelitis, and chronic osteomyelitis.
Yes, sir. Yes, sir.
So this is your task for the next short presentation based on your today's
Sure.
class. Okay.
Sure, sir.
Gopakumar sir, request for summing up the today's case, sir.
Yeah, it was a good case and good presentation also. Yeah. So I think we discussed quite a lot right from the history, clinical findings, radiological findings, and treatment. We have gone through most of the things. I think it was a good experience for everybody.
Thank you, sir. The short presenters. Avinash?
Yes, sir.
Please share your screen. And once Avinash finishes, the another presenter, please be ready. Avinash, share your screen.